Hello, I'm Marwan Abourass. Today, I'm going to answer the two critical questions posed by Dr. Musa al-Huraishi and many of you in response to my video on the ICDC protocol. The first question, do endodontic medicaments cause harm if they provide no benefit? The second question, can young dentists leverage these medicaments as a safety measure to prevent pain, thus gaining the reputation of painless dentist? First, you all know there is a biologic harm, treatment technique harm, procedural harm, patient relationship harm, financial income harm, and of course, legal harm. These criteria, if we use to apply to the different medicaments, we will know a lot of answers. In the 1900s till the 1950s, we used Eugenor and CMCP, relatively harmless. Then they used triarsenic acid to devitalize the pulp, very toxic. And today we use calcium hydroxide as intracanal medication. Calcium hydroxide is excellent for vital pulp therapy, but not as intracanal medication. It has many harmful side effects in the technique the way we use it today, especially the use of the non-setting material. There are three kinds of risks with the use of calcium hydroxide as we do it today. Number one, during the delivery into the canal. Second, while the calcium hydroxide resides in the canal. And third, when we try to remove it. The delivery risks are associated with using injection syringe. Pressure syringes cause overextension of this caustic 12% 12 pH alkaline into the tissue and the neighboring critical neurovascular bundles, incisive foramen, sinus floor, nasal floor, and most notably the facial spaces, especially the infraorbital. When it comes in contact with tissue, immediately cause necrosis. We had many patients has to be hospitalized because of this. And after that, we had to take care of them for between 1 month to 3 months of follow-up till the tissue you have healed and returned to normalcy. Another risk in delivery is the use of lentula, rotating at 1,000 RPM, especially if faces and diagnosed curvature, it will fracture. And now we have a new problem. The risks when the calcium hydroxide in the canal, it is ineffective against Candida albicans and E. faecalis. Those two bacteria are responsible for endodontic failures and the formation of AP. And many attempts have been made to increase the efficiency of calcium hydroxide by adding iodoform, ibuprofen, ciprofloxacin, and many other materials. There's no optimal solution. There is no need for it. And if to be effective, it has to fill the whole canal, which is a very difficult job. And the last is the difficulty during removal. Everything has been tried, and it will always leave a smear layer and fill the accessory canal, the lateral canals, the fins and fissures. They have used 17% EDTA. They have mixed ADTA with sodium hypochlorite. They use passive ultrasonic agitation, acetic acid 20%. All of this failed to remove the last 2 to 3 millimeters at the root end, which is the apical 1/3, which is the most critical. And with time, The calcium hydroxide remaining as a smear layer will resorb, leaving a space, and the space will cause apical micro leakage. It doesn't make sense to complicate endodontic treatment. I have always been committed to simplifying endodontics. In summary, my friends, once you are a biologically evidence-based clinician, you will know. You will know what's harmful, what's not. One day, I was a young dentist like you. I have used CMCP once or twice. I never used formicresol in my life. I have always targeted straightforward, simple endodontic procedures. But calcium hydroxide intramedicament is not in my dictionary. It's not in my technique or philosophy. And my philosophy is the ICDC, and my best and most important medicaments, 2.5 sodium hypochlorite. It is the best and ideal medicament delivered into the canal in drops. Thanks for listening.